Endoscopic surveillance after surgical or endoscopic resection for colorectal cancer, European Society of Gastrointestinal Endoscopy, ESGE, and European Society of Digestive Oncology, ESDO, Guideline. Introduction. Endoscopic surveillance after surgery for colorectal cancer, CRC, requires a multidisciplinary approach among several specialties, including endoscopy, oncology, and surgery. Its relevance is expected to increase in the near future, being directly related to the high prevalence of CRC, which now ranks as the third most prevalent cancer in Western countries. The role of surveillance endoscopy in this setting relates to detection of metachronous and recurrent CRC and its efficacy in thereby improving outcomes for CRC. This is in contrast to the setting of post-polypectomy colonoscopy surveillance, where clinically relevant precancerous lesions, rather than already developed CRCs, are the main target of the intervention. Surveillance colonoscopy represents the primary modality for prevention and early detection of metachronous CRC and is usually integrated with other biochemical and radiological tests for detection of local and distal malignant recurrences. However, endoscopy capacity is limited, so appropriate use of endoscopy resources in surveillance post-CRC surgery is desirable. Endoscopic surveillance is also performed following complete endoscopic resection of early invasive CRCs, previously known as malignant polyps. The rate of early CRC amenable to endoscopic resection, i.e., with low risk of lymph node or distant metastasis, increased dramatically with implementation of organized programs. Approximately 10% of CRCs diagnosed in fecal immunochemical FIT-based programs are removed endoscopically, accounting for nearly half of all CRCs detected at an early stage. The aim of this joint guideline by the European Society of Gastrointestinal Endoscopy, ESGE, and the European Society of Digestive Oncology, ESDO, is to provide guidance on use of colonoscopy surveillance after surgery for CRC, as well as after complete endoscopic resection of an early CRC. Main recommendations. 1. The authors recommend post-surgery endoscopic surveillance for CRC patients after intent to cure surgery and appropriate oncological treatment for both local and distant disease. Strong recommendation, low-quality evidence. 2. Hassan et al. Recommend a high-quality perioperative colonoscopy before surgery for CRC or within 6 months following surgery. Strong recommendation, low-quality evidence. 3. The authors recommend performing surveillance colonoscopy 1 year after CRC surgery. Strong recommendation, moderate quality evidence. 4. Hassan et al. Do not recommend an intensive endoscopic surveillance strategy, e.g., annual colonoscopy, because of a lack of proven benefit. Strong recommendation, moderate quality evidence. 5. After the first surveillance colonoscopy following CRC surgery, the authors suggest the second colonoscopy should be performed 3 years later, and the third 5 years after the second. If additional high-risk neoplastic lesions are detected, subsequent surveillance examinations at shorter intervals may be considered. Weak recommendation, low-quality evidence. 6. After the initial surveillance colonoscopy, Hassan et al. Suggest halting post-surgery endoscopic surveillance at age 80 years or earlier if life expectancy is thought to be limited by comorbidities. Weak recommendation, low-quality evidence. 7. In patients with a low-risk PT1 CRC treated by endoscopy with an R0 resection, the authors suggest the same endoscopic surveillance schedule as for any CRC. Weak recommendation, low-quality evidence.